Am I audible?
Yes, you
So good evening, everyone. Welcome to the Rule Service Boot Camp. So we have a sixth webinar today, and today's topic is also a very important topic, very commonly seen in bond centers, and will be a topic you'll be coming across daily, or at least every other day. So today's topic is approach to a breathless patient, and we'll be dealing with basic assessment, treatment, and differentials of an adult breathless patient. So we have two speakers today who will be taking the class. So we'll have Dr. Tejo Thomas, who's from the batch of 2015 and a junior resident in the Department of Critical Care Medicine in St. John's. And we also have Dr. Prem Prakit today, who's a resident in the Department of Critical Care Medicine, St. John's. And I think we are good to go. So over to you, Tejo.
Thank you, Jatin. Welcome all to today's session. We will be starting with no further formalities. We are approaching a talk. We are doing a topic on approach to a breathless patient, which is the sixth webinar in this Rural Service Bootcamp series. And we'll be dealing with very basic things such as we are expecting uh, people to be working from a rural area, rural setup with resource limited conditions. So we will be trying to handle the case in a way that we will be able to assess the patient and manage the patient with the existing setup. We'll be focusing mostly on history and examination, and further we'll go through four case scenarios, which I think will be the most useful part. Because didactic lectures have been there during our UG time. So more than that, interact better during the case scenarios. That will be most useful. Please don't hesitate to speak up. We have all been there. I've been the shy guy in the webinar who don't want to speak up. So I understand, but it's totally okay. It's a closed circle. It's a very close circle of 10, 15 people as of now. So try to interact as much as possible. Uh, what is dyspnea? Dyspnea, by definition, is a subjective experience of breathing discomfort that qualitatively vary in intensity. But if you want to term it in one word or a single sentence, we'll call it an uncomfortable, abnormal awareness of breathing. This is what we are familiar with during our UG time also. It is an indicator of inadequate ventilation or insufficient oxygen in the circulating blood. Uh, so when a patient comes to you, how can the patient describe it? So patient can come with a history saying that he cannot get enough air, or there's a hunger for air, or there's a tightness in the chest, or air all the way down, or there's a choking sensation. So as you can see, it's a subjective symptom reported in different ways by the patient. All of this can be dyspnea history, but there are a few terms which you need to know regarding dyspnea. So we'll be dealing with tachypnea, orthopnea, platypnea, trypopnea, bendopnea, hyperventilation. You would have all heard these terms. So what's tachypnea? Tachypnea is basically just increased rate in increased respiratory rate. Orthopnea will be discomfort while lying flat, and which is mostly seen in heart failure, left heart failure. Platypnea is breathlessness while sitting upright, which is commonly seen in right to left shunts, such as in waiting for an OL and ASD. Trypopnea is breathlessness while in lateral decompression, when the patient is lying towards the side, which is most commonly seen in unilateral lung diseases, and the patient prefer to lie and sleep on the opposite side of the diseased lung. As with gravitation, the perfusion and ventilation increases. Which is an exception to this is pleural perfusion, where the patient will sleep on the opposite side. Bendopnea is discomfort by leaning forward. This is a relatively new term, which is seen in heart failure when the patient has shortness of breath bending when he or she bends forward, when there's increased ventricular filling and there's increased pressure. Hyperventilation is when ventilation is in excess of the metabolic need, mostly seen in metabolic acidosis, where the patient will be hyperventilated. Other key points we have to notice the use from my experience and most of the bond centers which I've seen, the available resources are mostly pulse oximeters, stethoscope, oxygen mask, and bivouac, and some centers might have a facility for intubation and chest X-ray. And but the most important thing which we have to rely on is the history and examination. because usually the cause of dyspnea will be evident from the complete history and physical examination, and rapid determination of the cause of dyspnea will be able to save lives. What you have to note is dyspnea is not necessarily a pulmonary condition. Shortness of breath can be because of other reasons as well. So if you have to look at the differentials of dyspnea, the patient can have cardiac causes, respiratory causes, and other causes. Most commonly, we'll be dealing with respiratory and cardiac causes. Respiratory will be dealing with mostly asthma, COPD exacerbation, pneumonia, and in some cases, pulmonary embolism and fluid effusion. Cardiac cases will be seeing mostly congestive cardiac failure and other conditions like congestive pericarditis and all that. Other reasons for dyspnea include neurological conditions such as in GBS, Guillain-Barré syndrome or myasthenia gravis, where there's a in respiratory depression and the nerves are responsible for that. Endocrine conditions like DK, diabetic ketoacidosis, where there's severe metabolic acidosis. And in conditions where there's huge blood loss or even fluid overload conditions, the patient will experience breathlessness. You have to look at the pathophysiology in a very basic terms. The two common reasons leading to the breathlessness would be decreased supply and decreased supply. Uh, Hi guys, am I audible or is it getting interrupted? If there's an issue with the audio, please let me know in the chat box. Okay. I'm assuming it is currently fine. So I'll be proceeding with the presentation. So looking at the pathophysiology, the two common reasons would be decreased supply or increased demand. So increased demand will be seen in patients with severe anemia, metabolic acidosis, when there's fever, when there's exertion and all that. Decreased supply would be seen in conditions where there's increased obstruction to the airflow, such as in COPD and asthma, when there's decreased compliance of the lungs, such as in interstitial lung disease and pulmonary edema, and when there's decreased capacity of the lungs, such as in pleural effusion, pneumothorax, and muscle weakness. But before we go into assessment of dyspnea, we should remember what Dr. Clever said in webinar 2 weeks back, which is basically an ABCD assessment. When the patient comes to you, first your approach should be in ABCD assessment, where you see if the airway is compromised or not. If it's patent, you have to secure the airway. Then, if you have to see if the patient is breathing with adequate chest size, you also have to see circulation is adequate, whether the patient's peripheries are cold, clammy, and look at the disability if there's any head injury or any altered mentation. And you have to look at the exposure, whether the patient is in hypothermia or not, and all that. If you haven't attended the lecture last week, the video link to the previous webinars will be put on academics group. Please have a look. So going into history, as we said in the beginning, I'm assuming most people are in resource limited setup and the class is very basic. We want to come to a provisional diagnosis from history and examination. So in history, we need to find answers to a few questions, starting from, is it actually dyspnea or any condition that simulates dyspnea? Is it a cardiac or pulmonary cause? What is the grade of dyspnea? Is there orthopnea or PND? What is the onset and duration of dyspnea? What are the associated symptoms and any variations to dyspnea? So with respect to, is it actually dyspnea or condition simulating dyspnea? What we can think of is angina. Angina will be a patient presenting with chest pain and maybe breathlessness. A patient could be malingering, where they have a particular motive behind that. Patients can be in panic attack, where the patients will be already in anxiety and there will be rapid breathing, where they will be hyperventilating. Or they could be in acidotic breathing, like in DCAT, which they show Kussmaul's breathing, which is a rapid breathing in a consistent pace. Or there will be increased demand, like in fever, septicemia. So necessarily, it need not be a pulmonary condition. All these conditions also simulate dyspnea. So to rule out whether it's cardiac or pulmonary, there are a few pointers. The first thing would be in pulmonary conditions, a cough would be preceding the dyspnea, and there will be associated expectoration. Whereas in cardiac cough is not prominent, it's usually patients with pulmonary conditions can also have fever, and the progression will be gradual over many years. Whereas in cardiac conditions, may not be a fever, and progression is rapid. Cardiac conditions classically will have another pointer, which is orthopnea or PND. Orthopnea is basically breathlessness while lying down, and PND is patients with PND will give a classic history of feeling breathless and getting up from sleep after 2-3 hours of sleep. Pulmonary condition, which will also give a history of prompt response to bronchodilators and oxygen, and it is not necessarily related to exertion usually. Cardiac conditions will be responding to diuretics mostly, and there will be usually there's still edema. When we are describing a history to another person, especially if you are in doubt and if you are asking senior help, it'll be good to give the gradation of the dyspnea. So predominantly we use NYHA grading for cardiac-related conditions and MMRC for respiratory conditions, which is not a hard and fast rule. It is something we generally follow. NYHA grading is taking into consideration of a patient's normal physical activities. So NYHA grade 1 with no dyspnea, and grade 2 will be slight limitation with physical activity. Grade 3 will be dyspnea with normal physical activities, where you don't expect the patient to have dyspnea. And grade 4 will be dyspnea at rest. Whereas in MMRC, there are 5 levels. The first one is grade 0 is no breathlessness. Grade 1 is breathless while walking uphill. Grade 2 is walking slower than breathlessness and walking slower than the pure. Grade 3 is breathless and stops for breath after 100 meters of distance. Grade 4 is too breathless to leave the house, or even breathless while undressing. So when minimal activities can lead to breathlessness. In grade 4. Other two would be onset and duration and variation. Onset, with respect to onset, we are looking at sudden onset breathlessness and gradual onset breathlessness. Conditions that lead to sudden onset breathlessness would be acute pulmonary thromboembolism, acute pulmonary edema, pneumothorax, foreign body aspiration, COPD, and bronchial exacerbations. And these are the conditions which we need to tend to faster because it can be life-threatening as well. In pulmonary thromboembolism, if you could pick up from the ECG, there's a Q3, T3 waveform and all that, it will be better to refer. Similarly, pneumothorax, if you could do a needle thoracostomy, it can be life-saving. Foreign body aspiration, if you can hear the stridor and if you think there's a foreign body, if you can do Heimlich's maneuver and dislodge the foreign body, it will be life-saving as well. So these are things which we need to do, which we need to attend to immediately. Gradual onset breathlessness would be seen in bronchial asthma, COPD, which is the most common causes, and it can also be seen in anemia, corona, other cardiac conditions. Variations, with respect to variations, I'm referring to the seasonal and diurnal variation of dyspnea, which is mostly seen in conditions like bronchial asthma, where there's increased symptoms during winter seasons or early in the morning. There's a classical pattern to breathlessness in cardiac conditions, which I mentioned earlier. One is paroxysmal nocturnal dyspnea, which is classically seen in left heart failure. Basically, patient will give a classic history of feeling breathless a few hours into the person's sleep, and after 2-3 hours, they'll get up from sleep and they'll try to go to the window, trying to get a breath of fresh air, which is a sign of impending left heart failure. Orthopnea is breathless immediately on lying down, which is also classically left heart failure. But it can also be mimicked by COPD or asthma triggered by gastric reflux and all that. PND can also be mimicked by postnasal discharge with severe cough or nocturnal aspiration in GERD cases. Other symptoms or other pointers which you have to keep in mind would be a severe central chest pain with difference in BP between arms can indicate aortic dissection, or in pulmonary embolism also the patient can have sudden severe pain. Fever can give a clue of infectious cause. Anxiety preceding dyspnea could indicate a panic attack or anything psychogenic dyspnea. Prolonged bed rest leading to acute onset dyspnea may indicate acute pulmonary thromboembolism. So examination I'll be dealing in detail in the case scenarios. Now, just to quickly summarize, examination we'll be looking at in cases of acute dyspnea. We'll be looking at the heart rate, respiratory rate, pulse oximeter reading. If they are using axillary respiratory muscles, if the patient having difficulty speaking full sentence, and does the patient have tried asymmetric response or percussion, leading to a percussion revealing dull notes or hyperintense, cyanosis, etc. Um, Chronic dyspnea will follow a stepwise approach, which will be people with a much more gradual onset history. Most common cause will be in asthma and COPD, which we'll be dealing with in the case scenarios. So if you have to quickly look at the algorithm, this is what we'll be looking at. The patient presents to you with breathlessness. If the patient is not stable, we'll secure the airway, we'll secure IV access, we'll see the patient again, and if the patient is the risk is eliminated, we'll go into history. We'll do a thorough physical examination and try to come at a provisional diagnosis. Further, we'll probably have chest X-rays in our center. Chest X-ray could reveal much more detail regarding the pulmonary condition. If there's no bronchovascular marking, if the one side is if you feel there's a collapse of lung, it could indicate pneumothorax. And if there's deviation of trachea, it could reveal tension pneumothorax. If there's just increased bronchovascular markings and hyperinflation, it could show a COPD and flattening of diaphragm. If the patient has a consultation, it could reveal pneumonia. So I was thinking of the normal breath sounds. I'm not sure whether it's audible. I don't. Okay, fine. So I'll be sharing this PPT with you later. This is basically breath sounds available on YouTube. A little distracting as of now. Basically, all the results are available on a page called Med School, which has bronchi stridor, V's, bronchial breath sounds. Try listening to it if you haven't got enough chance to examine the patients during your UG. This will be helpful, or if you want, it will be a ready reckoner if you want to just listen to it otherwise. Examination and this is basically the use of axillary muscles in a patient. So this will also be helpful. You will see basically trapezius, scalene muscles, and sternocleidomastoid muscles being used for respiration. That will show the use of axillary muscles. That will indicate the patient is in respiratory distress. So we're going into case scenarios. And Dr. Prem, is there anything that you want to find? Do you want to please summarize?
No, you proceed. I'll discuss the case.
I hope somebody will respond in this case scenario section. Please feel free to contribute to this. If nobody volunteers, I might have to ask somebody to volunteer. Okay. Case 1. Can somebody read this scenario out? Jaren, are you there?
Yes.
Yeah.
Am I audible?
Can you just read this history, please? Yeah, you're audible.
Okay. Mrs. Mary, a 23-year female patient, comes to your clinic with history of cough and wheeze from past 2 weeks. It all started with fever and running nose 2 weeks ago. Fever subsided, but cough and wheezing is continued. It's more in the early morning and she has symptoms every day since then. There is similar past history of cough and wheeze on and off since 2 to 3 years. And she takes aspirin inhaler for such episodes and is completely relieved. She also has history of itching and skin rashes occasionally.
So, as you can see, the history is clearly indicating something. From what you read, what do you think, Jaren, this is?
Mm.
So there
More
are,
to
uh, yeah, go ahead.
pulmonary cause.
Yeah, so we can see the patient is having wheeze, and the patient had a history of similar past history in the past, and she's taking an inhaler, and there's multiple episodes in the past which is relieved when the patient is using an inhaler, and there's also a history of itching and skin rashes indicating atopy. So we are looking mostly, and it's a young female, uh, predominant complaint being wheeze, which aggravated after the infective episode. So we're looking at an exacerbation of asthma mostly. And if you want to look at the examination findings, uh, Karin, can you read this?
Examination, general survey, propped up, no cyanosis, respiratory rate 30 breaths per minute. Inspection, accessory muscles of respiratory used, shape of chest normal, palpation, trachea in central position, vocal fremitus decreased uniformly, percussion, resonant or hyperresonant, auscultation, vesicular breath sounds diminished uniformly, VC is present.
So as I had already given away the diagnosis, basically we are looking at a case of exacerbation of bronchial asthma. So good job. Thank you, Jaren. Um,
So,
yeah, sir.
yeah, so can you just go back to the slide, the case scenario? So, Jaren, are you there?
Yes, sir.
So, why do you think that this is asthma?
She has a past history of using
Okay, so
aspirin in
this patient, suppose such a patient comes to you with such complaints. Okay, so this patient is presented with breathlessness and cough. Okay, so what all points you will see for in the history you'll ask for to arrive at a diagnosis? Can you just tell? So this is a very common scenario, right? Patient presenting with cough and breathlessness. It could be anything. It could be cardiac. It could be respiratory cause. It could be anything, right? So why do you think that this is asthma?
first we will ask for the onset and pro like duration of
Hmm.
the symptoms.
Hmm. Okay, so the main concern here is differentiating a cardiac cause of breathlessness from a respiratory cause of breathlessness, because treatment is entirely different for both, right? So treating cardiac breathlessness is because of pulmonary edema, right? Because of the left ventricular failure. While so that is basically treated with your diuretics. But your respiratory cause of breathlessness, if it's asthma or COPD, something like that, it's usually treated with bronchodilators. So the treatment is entirely different. And if you give bronchodilators to a heart failure patient, what is going to happen? You're going to worsen the heart failure, right? Because most of your bronchodilators are sympathomimetics, your beta agonists or methylxanthines, all those things. They're beta agonists or sympathomimetics. It's going to cause tachycardia that can worsen heart failure. So it's very important to differentiate both. And your patient is not going to improve, your heart failure is not going to improve with bronchodilators. So that's why it's very important to differentiate clinically when you have such a patient. The differentiation is purely based on history and examination. You don't have a lung scan, you don't have an echo in the primary healthcare setup, right? So basically, it's purely clinical history and examination that will give you the diagnosis. So in this patient, so you can see that there is so basically you have to differentiate a respiratory cause from a cardiac cause of breathlessness. So can you tell me a few points that by which we can differentiate cardiac and respiratory? Chiran?
Anybody else want to volunteer?
Okay, I'll tell. So, cardiac breathlessness and respiratory breathlessness. So, usually, in a patient who is having a respiratory cause of breathlessness, the predominant symptom initially would be cough. So, cough, patient will start having cough, then it will progress, then later patient will start having breathlessness. So, cough is the first symptom usually in a respiratory cause, while cough is a later symptom in cardiac cause. In cardiac cause, usually breathlessness comes first, followed by cough. That is one thing which it's how we can differentiate one thing. Second, in respiratory, usually they'll have history of wheeze. So wheeze is a symptom of bronchospasm. Obviously, wheeze can be there in cardiac failure also, but most commonly you'll have history of wheeze in a respiratory cause. And the next thing is history of orthopnea or PND. So if the patient is orthopneic, so orthopnea can be there in both respiratory and cardiac cause of breathlessness. While PND is classical of cardiac cause of breathlessness, which PND indicates that there is left ventricular failure. So if the patient is having PND history, it's 100% sure that the patient is having a heart failure related breathlessness. Then any history of nebulization. So breathlessness responding to nebulization indicates that patient is having a respiratory cause of breathlessness, while breathlessness responding to diuretics indicates a heart failure related breathlessness. And suppose if the patient is having history of atopy, skin allergy or food allergy, childhood history of wheeze, a family history of wheeze, it's more likely that the patient is having a respiratory cause of breathlessness, predominantly, usually asthma. Smoking history with long-standing breathlessness can be COPD, but again, smoking is a risk factor for ischemic heart disease. They can have coronary artery disease. They can have cardiac failure also. So all these points you can ask when you take history. This patient, you have cough and wheeze. She's a young female, 23-year-old, no comorbidities. She's unlikely to have a coronary artery disease. She's unlikely to have any other heart disease except a congenital heart disease, which can present at this age. And the symptoms is been exacerbated by fever and cough. So cough with early morning cough. It's again pointing towards asthma. And there is history of nebulization, say history of Asthalin inhaler intake, and history of wheeze prior to this admission. So all these indicates that there is it's more towards a pulmonary cause of breathlessness. He has history of atopy also. So this tells that most probably she is having a respiratory cause of breathlessness, and our probable diagnosis is asthma. And so these are the points which we can see in the history. And for examination wise, nothing much we'll get in asthma except you might have a bilateral V's. That's the only thing most commonly that we used to get in an asthma patient. But if patient is in severe respiratory distress, obviously they can have altered sensorial, they can have axillary muscle usage, they can have hyperinflated chest. In long-standing asthma, they can have. So all these points you can see from the examination also. Yeah.
Yeah. So yeah, going to the management, we'll be giving oxygen support and predominantly we'll be giving nebulizations. Nebulization with salbutamol is the primary choice. We can give one respirol every 20 minutes for up to 3 dosage. If there's good response, we can increase the interval to 3 to 4 hours. And if the patient is using, or if they only have aspirin inhalers with them, they can use the inhaled aspirin, one actuation and 4 to 8 inhalations every 2 3 minutes. One thing we have to make sure is the technique of using inhaler should be correct. They should be ensuring a proper seal around the inhaler, and they should be taking multiple inhalations after one aspiration. In severe asthma, we can give IV hydrocortisone as well. For a diagnosis
So
of
this is basically the
asthma,
management of acute asthma, acute exacerbation of asthma. When it's a mild to moderate exacerbation, you can do all these things in your setup. But if it's a severe exacerbation, probably little more aggressive measures we may have to offer, probably early mechanical ventilation, early intubation and mechanical ventilation, and IV bronchodilators we may have to use, even IV anesthetics and inhalational anesthetics also we may have to use. So all these things, what he has mentioned is basically for mild to moderate exacerbation of asthma. Severe exacerbation, you can initiate treatment, and as soon as possible, you may have to refer the patient to the higher center.
So for a diagnosis, we generally need not a doctor, need not need the diagnosis of asthma. We will be treating the acute episode. But if you want to give a proper diagnosis, we can establish the diagnosis using a peak expiratory flow meter, which is available in the peripheries. It is not that expensive as well. So we can check the peak expiratory flow before giving a shot of aspirin, 400 micrograms per, and after the administration of the bronchodilators, we can check the peak expiratory flow again. And the highest PEFR minus lowest PEFR by highest PEFR in 1000 will give the percentage. And if the reversibility is more than 15%, it's diagnostic of asthma. What if you notice, this can also be used to rule out, like not rule out, indicate less than 15% reversibility is seen in COPD. Whereas in asthma, you will see more than 15% reversibility after administering the bronchodilators. Going into case 2, can somebody volunteer for this as well? Can somebody read out the case scenario? Don't worry, we have all been there. I was also shy in most of my webinars to answer, but then what I realized is when we take part more, this will be remembered in even like when we are in our final year exams. We'll mostly remember what stuff we said during the class or what cases we presented. So if you interact better, it will help us to know better as well. Can somebody volunteer to read this case? Alan Roy? Alan, are you there? Okay. If nobody's volunteering, I'll go ahead. So case 2, it's Mr. Janardhan, a 55-year-old male, presenting to your clinic with fever, productive cough, shortness of breath, and mild lower chest pain for 7 days. In the known case of diabetes on regular treatment and sugars are under control. On general examination, the temperature was 101 degree Fahrenheit, SpO2 was 93% on room air, heart rate was 88 beats per minute, respiratory rate is 18 beats per minute, and BP was found to be normal. So at this point, we get to know the patient is an elderly male coming with predominant symptoms of fever, productive cough, and shortness of breath, and there's a chest pain in 7 days. So something, the fever and the productive cough indicates more like an infective pathology in the respiratory system. Vitals and general examination, there are no particular findings except the slightly low saturation and the temperature. Going into examination, so inside was no abnormality. The axillary muscles of respiration was working. Diminished movements of left side of chest was present. Palpation, the left side movements of chest was restricted, and trachea was in normal position. Vocal firmness was increased on the left side. Percussion, there was a woody dullness on the left side, and oscillation findings revealed the high-pitched bronchial breath sounds and increased vocal resonance. And there was coarse crepitations present, mostly in the left side of the chest. So from inspection, the findings we are getting, the positive findings are inspection, there's diminished movements of the left side of chest, on palpation, there's mostly restricted movement of the left side of chest and increased vocal parameters. Percussion does indicate there's a dullness on the left side. So mostly the pathology is um, seen in the left side of the chest. And auscultation findings, you get two the added ones. One is there's coarse crepitations present, and there's high pitched bronchial breath sounds. So, Prince, do you want to take over?
Yeah, so this is typically history. Can you just go back to the scenario?
Yeah.
Scenario. So this is just a short history of fever, productive cough, and shortness of breathing difficulty. Who is a diabetic? So there is no other comorbidities. Obviously, the character of breathlessness here, as I've told already, there is productive cough with breathlessness predominantly. It should be a cardiac cause. Obviously, you have to rule out I mean, sorry, it's a respiratory cause of breathlessness, but again, you have to rule out a cardiac cause of breathlessness also, especially if the patient is elderly, 55-year-old, she is a diabetic. So you can have associated ischemic heart disease or coronary artery disease also. So in such a condition, you have to have like proper history and clinical examination to arrive at a diagnosis. Maybe sometimes patient can have an infective exacerbation of COPD, or it can have a pneumonia. That pneumonia can any underlying infection can exacerbate a heart failure. So majority of the times when we see both respiratory failure, I mean respiratory and cardiac cause of breathlessness may coexist. So you may not be able to differentiate clinically. You may have to go in for further investigations later. But this is a typical history of a patient who is having pneumonia. So short duration of symptoms, fever, cough, productive cough, and breathlessness should be pneumonia. And further diagnosis has to be made depending upon the clinical examination also. And for that vitals, uh, he is febrile, he is hypoxic. So as of now, BP is normal. So all these points towards diagnosis of pneumonia. And the examination findings in pneumonia, as you can tell, there is respiratory distress, there can be axillary muscle usage. And wherever there is pneumonia, that side, the chest movements will be less. So the diminished movements are on the side of the chest because the lung is consolidated. The expansion of lungs will be limited on that side. So the movement of the chest wall will be diminished on that side where there is pneumonia. And other signs which we can see for is a increased vocal parameters in a peripheral setting. If you don't have much facilities for a lung scan or an ultrasound or a chest X-ray, you can just do all these clinical examination methods. You can do a vocal parameters, whether it's increased or not. You can percuss and see whether there is dullness on that side. And auscultation usually will get there's a dense consolidation, you'll get a high-pitched bronchial breath sound. That's basically a tubular bronchial breath sounds with coarse crepitation. So all these things you can use as a method to diagnose pneumonia clinically. So if it is pneumonia, then treatment you can just do. So most
Yeah.
common diagnosis here is pneumonia. You can confirm the diagnosis with an X-ray. So this is the X-ray. You can take.
Yeah. So some centers will have X-ray, and as evident from the history, this patient had more pathology most in the left side, and in the X-ray also, what you can see is the consolidation in the left side of the lung, and you can see air bronchograms, and there's minimal effusion there's effusion on the left side as well. So these are the findings which you can expect in pneumonia, and the reason for the woody dullness would be in the consolidation. And if there's stony dullness towards the basal region, it can indicate pleural effusion, the pneumonic effusion after the pneumonia takes place.
So in this X-ray, why is it consolidation? What are the features favoring the pneumonia in this X-ray? Can anybody tell?
Homogeneous patch air bronchogram.
Yeah, so basically there is a non-homogeneous opacity you can see on the left side, because you can see varying densities. You can see a full very much white areas as well as some grayish and black areas also. You can see air bronchograms within the opacity, and you can also see that there is no mediastinal shift and there is no volume loss. So that indicates that the patient is just having a consolidation on that side. So what are the other DDs for this type of an X-ray? If there was no air bronchogram, if it was a homogeneous opacity, what are the other DDs? What are the possible DDs? So the other possible DDs are one is pleural effusion. If there is a pleural effusion, you should look for the costophrenic angle, whether it's blunted. Usually you will have a homogeneous opacity. It's a pleural effusion. You will be able to see the upper level of the effusion, and they can have a mediastinal shift if it is massive. So all these are the things which you have to see for in a pleural effusion. Other DDs are collapse. One is collapse. So in collapse also there can be a volume loss features on that particular side wherever there is collapse. They can have mediastinal shift. The appearance will be almost the same. They may not be having a air bronchogram. Other thing you have to see one DD which we can miss is a pulmonary embolism. If there is a pulmonary infarction associated with pulmonary embolism, that can also present like this. It can be mistaken for a pneumonia consolidation. That also has to be kept in mind, has to be correlated clinically. The history and examinations are the things that can differentiate all these.
So just to quickly summarize, we'll be able to come to a diagnosis even to a provisional diagnosis even without X-ray. If there's a history suggestive of acute lower respiratory illness with a cough, with expectoration, shortness of breath, fluid, chest pain for less than a week, and there's a systemic feature with fever, chills, and anger, and new onset bronchial breaths to crackles, and no other explanation of the illness. And obviously, X-ray will be helping in our diagnosis. So going to management, we'll have to general management. We'll be giving the patient adequate rest and nutritious diet, and the main treatment would be through antibiotics. And other symptomatic management will be providing oxygen support, IV fluid, chest physiotherapy, etc. Antibiotics will prefer an oral macrolide like azithromycin for the 3 days, and probably for a mild pneumonia, we can also give beta lactams as well. But the depends from center to center and the severity of the condition. So this is a very basic way to tell. But the management depends on the severity of the condition. So anything you want to add for management?
So basically, if clinically you have diagnosed the pneumonia, it's very important for you to classify whether it's a severe pneumonia or a mild pneumonia. So if it is severe, you can always initiate the treatment and try to refer the patient to a higher center, because they can have all sort of complications. Pneumonia can worsen, they can have severe hypoxia requiring other measures of achieving oxygenation. They can develop multi-organ failure, so which may not be able to be managed in the primary care setup. So you may need an ICU setup to manage all those conditions. So if it is mild pneumonia, you can always treat. So the score which we can use, it's a simple score, it's a SCRP 65 score, which we can use to classify. And accordingly, we can treat, and close monitoring is very much essential for the progression of or worsening of symptoms. If the patient is having an infection somewhere inside. Yeah. So this is a SCRP 65 score. Yeah.
So it's a handy tool which we can use in a facility. So this is a score basically, and if the score is above 3 and more, it will indicate admission to a critical care setup. And a score of 2 will indicate admission is required, and 0 to 1 can be managed in outpatient setup. So a patient with new onset confusion, urea greater than 20 milligram per deciliter, and respiratory rate more than 30 breaths per minute, blood pressure 90, systolic blood pressure less than 90, or age more than 65. All these are scored 1 point each. And if the total is more than 2, it indicates the patient needs admission, and you will have to refer the patient if you don't have enough facilities in your center. Going into case 3, can somebody volunteer? If nobody is there to volunteer, we'll have our friend Nathaniel answering the case scenario. Can somebody volunteer? Can you read out this case?
Kamalamma, can you read? Hello?
Yeah.
Kamalamma, a 54-year-old woman presented to you with shortness of breath for 4 months that progressed to an extent that she was unable to perform daily activities. She also used 3 pillows to sleep and often woke up from sleep few hours after going to bed due to difficulty catching her breath. Her medical history included hypertension, dyslipidemia, diabetes, and history of triple bypass surgery 4 years ago. Her current home medications included aspirin, atorvastatin, amlodipine, and metformin. On physical examination, her vital signs are stable. Physical examination showed bilateral diffuse crackles in lungs, elevated jugular venous pressure, and grade 2 plus pitting lower extremity edema.
So, going into examination.
Her respiratory rate was greater than 20, heart rate 110 beats per minute, appears breathless, BP 90/60, bilateral pitting pedal edema and cyanosis were present. On inspection, bilateral pitting pedal edema, distended jugular veins, elevated JVP. On palpation, laterally displaced apex beat, hepatomegaly was seen. On percussion, there was abdominal dullness, and on auscultation, inspiratory bibasal crackles, not clear down coughing, diminished breath sounds, cardiac murmurs present, pizza in mitral area, sound respiratory.
Yeah.
So, yeah.
Yeah. So going into history, we can see the patient had it's an elderly female who presented with shortness of breath, and it was there for a long time, and it has progressed, and she is unable to perform her daily activities. And as you can see, the patient class the striking features of the patient already had edema, and the patient was given a history of PND, where the patient often woke up from sleep after a few hours going to bed, and the
So what,
near,
can you just tell, can you just analyze the symptom?
Here, she's an elderly female.
Yeah.
And it looks like the shortness of breath had started first, and since 4 months it has progressed.
Yeah.
And there is history of orthopnea, PND.
Yeah.
So there is also comorbidities of hypertension, diabetes, dyslipidemia, and also bypass surgery was done. It points towards the cardiac cause for me.
Yeah, definitely. Very good. So the points which are favoring a cardiac cause of breathlessness here are she's an elderly, 54-year-old. She's having multiple comorbidities, hypertension, diabetes, dyslipidemia, history of triple bypass surgery. So all those indicates that he's having an underlying heart disease, but even then, patient who is an elderly, who is having multiple comorbidities, we should always suspect underlying coronary artery disease in them. And she has presented with shortness of breath, progressive shortness of breath for 4 months. So So she was unable to perform daily activities, it's mentioned, and she's having orthopnea and PND. Uh, so which classification, uh, uh, class, which score you will use to classify such a symptom? Whether we want to grade it according to NYHA or MMRC? So this is a cardiac
Hello?
cause of
Yeah.
cardiac cause of breathlessness, right? So uh, which uh, which classification you want to use?
NYSE classification.
Yeah, NYHA. So can you tell me the NYHA class for this patient? Just can you just tell? The patient is having difficulty in performing daily activities. And one more thing is patient is having PND. So PND is which class of NYHA?
I
So
think it's 3. Is it
yeah,
3?
yes. So if the patient has PND, then patient is in NYHA class 3. Okay, PND is NYHA class 3. So the patient is having grade class 3 NYHA. So what could be the reason for the heart failure? So you know that now the patient is having heart failure clinically. What are the causes of heart failure in a 54-year-old female? Can you just tell? If suppose patient has presented features of heart failure, there is no other comorbidities, no diabetes, hypertension, nothing. What are the possibilities? Similar history, 54-year-old male, progressive breathlessness, now having PND, as presented to you. You want to think of coronary artery disease still?
Could be or undiagnosed hypertension leading to heart failure.
Okay, so the thing is, it could still be a coronary artery disease because age itself is a risk factor for coronary artery disease. Okay, it's a non-modifiable risk factor for coronary artery disease. So first possibility is always a coronary artery disease or an ischemic heart disease. Any other possibilities? Very common. So we should be thinking of anemia. Such a patient comes. Okay, anemia is one of the very common cause of gradually progressive breathlessness. Okay, so anemia you have to rule out. Anemia can cause global myocardial dysfunction, biventricular failure, everything. So that is another DD that you have to be keeping in mind. Any other cause in India? So we should be thinking about valvular heart diseases also. Okay, especially in India, commonly the rheumatic heart disease, chronic rheumatic heart disease, especially mitral valve disease, can present with gradually progressive breathlessness and PND. Understood. So typically the mitral stenosis, they'll have fatigue and progressive breathlessness as a predominant symptom. Okay, so valvular heart disease you have to think of. Any other cause? Cardiomyopathies. Okay, especially in elderly, they can have ischemic cardiomyopathies. Also, other cause of cardiomyopathies could be nutritional. It could be genetic cause of cardiomyopathies. They typically present with a post progressive worsening of breathlessness, PND, and obvious like typical heart failure symptoms. Any other cause? Can any pericardial disease present like this?
TB pericarditis.
Yeah, okay. TB pericarditis can present, but they'll present usually, those people can present usually with a right heart failure symptoms. Okay, right heart failure, but again, they can have left heart failure symptoms also. That also is one of the DDs. Any other cause? So you should be thinking of congenital heart disease also. Which congenital heart disease can present at this age? Yeah, any which congenital heart disease? So congenital heart disease, usually the bicuspid aortic valve, they can present at this age, and small, very small ASDs can present at this age. Pulmonary stenosis can present at this age. So all these congenital heart disease can also present at this age. So if a patient comes with heart failure, you have to be thinking of all these causes. It could be a myocardial disease, it could be a pericardial disease, it could be a valvular heart disease, it could be a coronary artery disease, or even it could be a congenital heart disease. So all these patients can present with features of heart failure. Okay. Most common in India is coronary ischemic heart disease. So this is typically a history suggestive of a left heart failure worsening congestive cardiac failure. You can see in examination, you can see uh, both signs of right heart failure as well as left heart. What are the signs of left heart failure?
Any other?
Pulmonary edema, crepitations
Yeah.
can be heard.
Yeah, so you can get fine end inspiratory crepitations in left heart failure. Other signs, anything else? On CVS examination, what can you get? So you can have a displaced apex. Okay, you can have an apex which is shifted out and down. You can have a heaving or a hyperdynamic apex depending on the hemodynamics. You can have an LV S3 in a heart failure. So all these things you can get in examination. Along with that, so if you have an S3 gallop rhythm with a bilateral basal crepitations and such a history, you don't need an echo to diagnose or to start treatment at least. So you can start treatment in your setup only, and you can refer the patient to a higher center. Okay.
So we have an X-ray of this patient. So as you can see, there's an increased CT ratio, there's increased vascular congestion. Classical we see in congestive heart failure would be a battling sign, whether it's by bilateral hilar condition, there will be curly B lines, increased CT ratio and all that, and there will be pleural effusion as well. ECG depends on the underlying condition. In this case, there was not much findings. So going into treatment, the patient we will have to provide oxygen as required and post in setting up position because the patient has orthopnea. And main step of treatment would be diuretics. We'll be giving Lasix 20 or 40 mg, dose every 2 hours, and depends on the response. In detail, other management, we'll also have to modify the other regular medications. Since the patient also has diabetes, we'll prefer ACE or ARB inhibitor and not a calcium channel blocker. And we'll have to monitor the patient long term. We'll have to advise the patient for the regular follow up and regular follow up. So every 3 months, the patient have to follow up, and probably within 2 weeks after discharge, we'll have to have a repeat visit. Regarding management, Professor, do you have to add in something?
So nothing. So just this giving oxygen, giving a proper position, and giving Lasix. So that can be done anywhere. Even if you're working in a peripheral center, you can do this at least this much, so that you'll get some time to
So,
see for. Yeah.
so just one question. Patient had BP of 90/60 with
Hmm.
Lasix can you give Lasix in this situation?
So any patient with decompensated heart failure, irrespective of BP, you can start Lasix. That is the dictum. Okay. See, once you decongest the LV, your BP is supposed to improve. So you can give a dose of Lasix even if BP is 90/60, then you can classify the patient accordingly. So patient can have, so if patient typically presenting with a history suggestive of cardiac failure, you have all these examination findings, you have diagnosed congestive heart failure clinically. Next step is giving a diuretic. Most commonly Lasix. Lasix you can, furosemide you can give. Then you can classify the patient whether the patient is having a low BP, normal BP, or a high BP. So if the patient is having a high BP, you can go in for drugs which are peripheral vasodilators like nitroglycerin, or you can give sodium nitroprusside, or you can give nesiritide, which is a BNP antagonist. Well, if the patient's BP is low, you can proceed with noradrenaline. So that's the management. Diuretic is indicated. That's the mainstay. One more thing which we can do is a positive pressure ventilation. You can give BiPAP or a CPAP trial.
Dr. Ritesh also has raises hand. Ritesh, do you want to add in something? He's a general medicine PT in CMC Vellore. Yeah, Ritesh.
Yeah, nothing. I just wanted to just emphasize on the fact that these patients acutely managed will be coming back to follow up with all of you. I hope I'm audible.
Yes, you are.
Yeah, so as Prem sir had clearly mentioned, I really believe that keeping their sugars controlled, their anemia corrected, is what is going to prolong their life. Because the mortality of a patient with an acute decompensated heart failure is quite high, and their recurrent admission rates are quite high. As we mentioned for the previous community-acquired pneumonia, vaccinating such patients is also critical if affordable. These patients, if they get a community-acquired pneumonia and they develop another decompensation, each admission is approximately going to cost them quite some amount, and also is going to worsen their mortality and outcome. The other
Yeah.
thing about the other thing I just wanted to mention, correct me if I'm wrong, if anybody is in doubt that Lasix can be started or not, and if you're in worry, give a bolus dose and start an infusion at least. That's the least you can do. Because if you don't relieve the pulmonary edema, as Sir has mentioned clearly, that the entire congestion will not come down and he is going to arrest. There is no way you can stop it. If you have the facility of an inotrope, please start on noradrenaline and start a Lasix infusion concurrently so that you can shift the patient. Positive pressure ventilation is again something you can do, but you should have an inotropic support also, because CPAP itself causes some hypotension. Again, this is for a center which has all of these facilities. If your center doesn't have all of these facilities, just be careful of the, give a stat bolus, relieve the acute pulmonary edema. And if it's always safer to load a patient, because you do not know if the patient has an NSTEMI, it's a very high chance that the patient can have an NSTEMI. So you can load the patient and you can always refer the patient. Otherwise, you can, if you feel, if you are very sure you're going to manage under yourself and you have an obvious reason for the acute decompensated heart failure, you can take the chance. I just wanted to add that. And the ACE-ARB part, I just want to mention that please make sure that you follow up their potassium and their creatinine. These patients are going to come back to you, and the first time you initiate an ACE-ARB, he's shifted from amlodipine to an ACE-ARB as per TIJO. So the amlodipine will also add to the pedal edema, and if I'm not wrong, the amlodipine CCBs are not actually recommended in an acute decompensated heart failure. It doesn't have any.
Yeah. So acute decompensated heart failure, only the mainstay is only diuretic. In chronic heart failure, your all other drugs, your ACE inhibitors, ARBs, your your beta blockers, evaporadine, digoxin, levosimendan, everything comes into play when you're managing a chronic heart failure case. So acute heart failure, mainstay is diuretic. That's why, irrespective of BP, you can give diuretic. That's what has to be done with concurrent inotrope vasopressor support or an inotrope support if you have. One more thing is, yeah, correcting anemia. It's a very important thing in heart failure. And regarding positive pressure ventilation, if you have signs of right heart failure, be cautious while giving positive pressure ventilation, because positive, see, your PEEP is going to affect your right heart badly, and PEEP is beneficial for left heart actually. So if the patient is having a predominant right heart failure also, then you have to do an echo to see for the RV dysfunction. You can, after putting positive pressure also, you can constantly monitor the RV function so that the PEEP can be titrated accordingly.
Yeah. Thank you, Ritesh. Thank you, Prem sir. So going into case 4, can somebody volunteer? It's almost going to wrap up. We have only two more scenarios. This one being the final.
Tejo, I have
Yeah.
another doubt. Sir,
Yeah,
most
go
peripheral setups,
ahead. No, Nathan.
most peripheral setups may not have an infusion pump. Could you give an idea of what we can do in those setups in terms of starting NORAD through like NS 500 ml? If you could like,
You can use dosimeters if you don't have a this infusion pumps, or if dosimeters are not available, you can just calculate the rate, drops, and adjust the rate. That's the only thing which is possible. You can start NORAD at around 0.05 to 0.5 microgram per kilogram per minute. That's the dose.
And if I may add, you can always, I think, always establishing. I mean, if you're the first contact and if she's going to further worsen, if possible, establish an EJV if you're capable of putting an EJV. Because if you don't have a central line axis, EJV is not as difficult as putting a central line axis, and you can give your higher doses of inotropic support through an EJV rather than a peripheral line.
Yeah. So if EJV also, if you are not able to put, then peripheral line is also okay. That's a recent this thing that they have mentioned. You can very well start vasopressor through a peripheral line also. But whenever the facilities are available, or your central line is available and the expertise is available, you can always put a central line. Otherwise, you can initiate vasopressors with the peripheral line also.
So going into case 4, who wants to take up this case? Who wants to volunteer? This is the second last case. If time permits, we'll go into the last case as well. Can somebody volunteer? Nathaniel?
Mr. Venkatesh, a 55-year-old physical training master, comes to your clinic with history of productive cough and breathlessness for 2 weeks. His sputum is yellowish and mucoid and has fever since few days. On further questioning, he complains of breathlessness on running and climbing stairs since few months, and he denies cough but admits that he brings out a lot of sputum in the morning and throughout the day since a few months. He has no chest pain, orthopnea, PND. He's a smoker from past 30 years, smokes one pack cigarette per day, gives history of using of inhalers. On examination, uh, general physical examination is normal and CVS is normal. Respiratory examination reveals crepitus in the right infrascapular region. Examination general survey SpO2 90, accessory muscle usage present, inspection barrel shaped chest, percussion hyporesonance, auscultation extensive V's, diffusely decreased breath sounds. X- X- X-ray showing flat diaphragm with hyperinflated lung.
So, to summarize,
Yeah,
Nathaniel, you want to go ahead?
yeah,
So the patient, yeah.
So this looks like a patient with a chronic, long-standing lung disorder that has progressively worsened over 2 weeks, with the history of breathlessness and the history of smoking as well. With the use of inhaler, it looks like a long-standing COPD that has exacerbated. So with because there's on examination there's crepitus in the crepitus in the infrascapular region. So maybe an acute infective exacerbation of COPD is what I would think of.
Uh, in this case, the probable diagnosis is infective exacerbation of COPD, as Nathaniel mentioned. And the classical findings we are looking forward to in COPD patients. Usually, we can see a bad chip test in some cases. On progression, the patient will have hyperresistance and wheeze is also present. And confirmation of COPD, like I mentioned before, can also be similar to the asthma condition. Post bronchodilator response of the peak expiratory flow will be less than 12%. Chest other investigation done will be CRD at we need to do a chest X-ray and for the findings which we saw. The treatment would, in this case, will include the treatment of the acute infective episode, which exacerbated the COPD, and we will have to manage the COPD as well. So we will be predominantly giving nebulizations, and in severe cases we can give steroid, though it's not preferred. Mostly in exacerbation, we stick to nebulizations and treat the underlying cause, which is infection. And for prevention in COPD patients, for prevention of the pneumonia, we can promote the use of the vaccinations. And bronchodilators are the way forward, and they will have to be using bronchodilators properly, and we have to ensure if the technique of using the bronchodilators is correct. Mainly, we have to advise smoking cessation, which is the only measure to decrease the progression of the disease. In this case, after managing with this much after management, the patient did not improve, and the patient is still having breathlessness. So we are expecting something else, and the X-ray showed this finding. Nathaniel, you want to take it? Nathaniel, are you there? So, as you can see in the X-ray, there's an area where there's no bronchivascular markings on the right side, and it indicates a collapse, and it is probably a pneumothorax. And in this condition, if the patient comes to a peripheral center with pneumothorax, if you can't do anything further, at least what you can do is you can do a needle decompression, which is a life-saving maneuver. Uh, we have to insert the wide bore needle, ideally 14 or 16 gauge, if possible, in the upper border of the lower ribs in second or fifth intercostal space. Earlier, they had preferred second intercostal, now fifth is preferred. In in fifth intercostal space, we'll be inserting the catheter. In second intercostal space, we'll be inserting a midclavicular line, and fifth intercostal space, we'll be inserting an anterior or mid-axillary line. So we have to be careful to insert the needle on the upper border of the ribs so as to not injure the neurovascular bundle. So this is some procedure we can do. Prince, do you want to add anything?
No, so always suspect if the patient is a non-case of COPD coming with breathlessness. Always it may not be a COPD exacerbation. So they can come with pneumothorax because the bull layer rupture. They can have spontaneous pneumothorax. So you should have a high index of suspicion of pneumothorax in COPD patients, especially. Patient is having already a hyperinflated lung. And always, once you have admitted the patient, especially in the ICU, where you are ventilating the patient or you have intubated and ventilating the patient, always positive pressure, they can have a spontaneous pneumothorax in COPD. So continuously, you will have to screen for pneumothorax, and you will have to be monitor. You should be monitoring the lung parameters, oxygenation, the compliance, everything, ventilatory parameters constantly in a COPD patient. And aggressive screening for pneumothorax also has to be done.
Okay. So,
And if the patient has developed pneumothorax, the emergency maneuver which we can do is a needle thoracostomy. So that you can use a wide bore needle to puncture the pleura. Usually was in the right second intercostal or whichever side where there's no right, the second intercostal space was preferred previously. Now in the ATLS algorithm they have changed to fifth intercostal space, especially in adults. In children it is still the second intercostal space which is preferred.
yeah. So we are almost winding up. So we are going to the last case. This may not be manageable in your setup, but then we can just go ahead with reading the next case. Can somebody volunteer? Say, call it from here. Sachin, do you want to volunteer? Sachin, are you there? Yeah. He has some net issues. Okay, I'll just go ahead with the case, and when Sachin is set with his network issues, he can join. So, case 5, it's a 46-year-old male presenting to the ED complaining of shortness of breath and pleurotic chest pain. He broke his ankle a week ago and has been in a car. Yeah, Sachin, are you there? Yeah.
Yeah, sorry. What is the role
Yeah, you can.
to the complaining short of breath and critical pain? He broke his ankle a week ago and has been in a cast since then. He was just discharged home after operative repair 2 days ago. History of presenting illness: 12 hours of worsening shortness of breath. Feels like it's hard to catch his breath, and it gets worse when he walks. For the last 2 hours, he's also been having sharp pleuritic chest pain to the right side of his chest. He has never experienced anything like this before.
Yeah. And examination?
On examination, his heart rate is 115 beats per minute. BP is 95/60. Respiratory rate is 18 breaths per minute, and oxygen saturation is 92%. CVS examination, rhythm is sinus tachycardia. Temperature is 37.2. Glucose is 6.3 milligrams per liter. PCS is 15. General status, CNS react to light, and there's no focal neurological deficit.
No head and ENT findings.
No ENT findings. RS, good air entry bilaterally. No adventitious sounds, mildly tachypneic. Abdomen soft and non-tender. Musculoskeletal, leg in fast.
So yeah, so Sachin, so Sachin, can you just tell me the DDs or probable diagnosis? Can you just tell? You want to try?
Can start with summarizing the positive findings in this case.
So there's a sudden onset worsening shortness of breath. So can you just tell a few DDs for acute onset severe breathlessness? Acute onset severe breathlessness, DDs.
Pulmonary embolism.
Yeah.
Pneumo.
So acute onset severe breathlessness, we have some DDs. So most commonly what acute exacerbation of COPD or acute exacerbation of bronchial asthma, tension pneumothorax, acute pulmonary edema, acute pulmonary embolism, foreign body aspiration. So these are the DDs of for an acute severe breathlessness. Okay. So if a patient comes to you with acute severe breathlessness, first thing that you have to rule out is a tension pneumothorax, because the treatment of tension pneumothorax is entirely different. It's a surgical management. So once you have ruled out tension pneumothorax, you have the other disease. Then you can see the analyze, take the history, examine, and arrive at the diagnosis, further diagnosis. So here the patient has, wait, can we just go back to the, so yeah, so the patient has acute onset worsening breathlessness, and there's a pleuritic chest pain. So coming to the examination, so he was bedridden. So that's a very important point. Bedridden patient presenting with acute onset breathlessness with a pleuritic chest pain. So what's the most common DD that you want to see? What's the probable diagnosis? Sachin.
So
Bedridden.
embolism.
Yeah. So it should be a pulmonary embolism. That's the most important thing that we should consider. In this case, patient will be tachycardic, tachypneic, obviously. If the embolism is massive, they can have severe hypoxemia and hemodynamic instability also. Can you tell what lung finding that you can get in pulmonary embolism? Lung examination, respiratory system examination. Apart from tachypnea, what else you can have? Apart from maxillary muscle usage or signs of respiratory distress, apart from cyanosis, what else you can have? Usually lung examination will be normal. So lungs will be completely normal usually if the patient is not having any other lung disease. Usually it will be normal. So you have a severely tachypneic, hypoxic patient is in shock, your lung is absolutely normal. You look for a DVT. You see the history. You analyze the history, whether the patient is bedridden, whether he has got any risk factor for developing a DVT or a pulmonary embolism. Then you can and patient other clinical signs you can see for patient whether he's having any signs of acute right heart failure. Then you can order for an ECG. You can see for the ECG changes. So what changes you expect in a case of pulmonary embolism? So usually most commonly ECG can be normal or can show some some like non-specific sinus tachycardia. It's the most common thing that we can get in an ECG. You can have S1Q3T3 as change also. There are several other ECG changes that can be there in pulmonary embolism. You can have RVBB, then a left axis deviation. All those things you can have, but S1Q3T3 you can just see for, and and sinus tachycardia. That's the most common thing. So S1Q3T3 is more specific for a acute, I mean, for a core pulmonary. So yeah, how do you treat? So once you have arrived at a diagnosis, there are other scores also. You can just go through that if you have time. Criteria, well score, all those things are there. But yeah, the diagnosis has to be made as soon as possible because it's a life-threatening cause. Life-threatening cause. So that you have to seek for. And diagnosis, there should not be any delay in diagnosis, especially if the patient is in hemodynamic instability. Then you have to arrive at a diagnosis. You have to initiate treatment at least as soon as possible. At the main thing you can do is the patient, if patient is taking hypoxia, you can give oxygen. That's the only thing you can do. If you have something, if the patient is hemodynamically unstable, obviously you have to intervene. You have to go in for a thrombolysis If you have streptococcus, you can give streptococcus, but ideally you have to use other agents, altiplase or tenecteplase, thrombolyse, pulmonary embolism. But at least if you have streptococcus, you can give streptococcus if there are no contraindications, and you can refer the patient to a higher center. But if the patient, if it's submassive pulmonary embolism, if patient is okay, patient's hemodynamic there's no hemodynamic insult, there's no severe hypoxemia, you can just wait. You can shift the patient as soon as possible to a higher center wherever thrombolysis or ICU setup is available.
Yeah. With this, we have everything. So I request everyone to fill in the feedback form. It is available in the chat box, and we'll be putting it in the joint academic group as well. I hope it was productive, and thank you all for interacting well. So all the people have taken up the case scenarios. Thanks to you, because that's why we all were able to learn. And thank you, Dr. Prem, for joining us on this fruitful session, for sharing your knowledge with us. We'll be coming back with another session next week. We'll update on the schedule as soon as possible. Thank you all. Have a good night.